Well, thank you for that kind introduction, and welcome to our BRCA carrier and Lynch Syndrome Fertility and Family Building event. So the majority of women with inherited breast and ovarian cancer carry a mutation in either the BRCA1 or BRCA2 gene. That being said, there are various other hereditary cancer predisposition syndromes and genetic mutations. Another one of the more common one is the Lynch Syndrome, which is a risk factor for colon, endometrial, ovarian, and stomach cancer. And women with a BRCA mutation are not only at increased risk of breast and ovarian cancer, as well as other cancers, but the risk of developing these cancers at a much earlier age of onset. And because the risk of developing these cancers at a much earlier age of onset, fertility and family planning becomes a major concern to many of these women and couples. And it also applies to anyone with Lynch syndrome or any other hereditary cancer predisposition syndrome. So a delay in childbearing combined with improvements in cancer survival rates have resulted in more and more women have not had children at time of the cancer diagnosis and therefore have the option of undergoing fertility preservation treatment. And oncofertility combines both oncology and reproductive medicine and expands fertility options for cancer survivors. And a significant portion of these young women who are diagnosed with cancer are given the opportunity to preserve their fertility before undergoing gonadotoxic treatment. Gonadotoxic treatment refers to cancer treatment like chemotherapy that can be very harmful to the function of the ovaries. So chemotherapy, as I just mentioned, can be very harmful to the ovaries, and the degree of damage is dependent on a few factors. Probably one of the most important of these factors is the type of chemotherapy, but the dose also plays a role, as well as the age of the women. And older women have less ovarian reserve and are therefore at highest risk of experiencing ovarian failure. So ovarian reserve is a common term we use in the fertility world to refer to one's egg quality and quantity. And women who have undergone cancer treatment without fertility preservation have been shown to have a substantial decrease in future fertility. And many studies looking at ovarian function following cancer treatment are often limited because they don't tell the entire story. Because most of these studies use menses, one's period, rather than pregnancy as an endpoint. And it's important to note that just because someone has a period, that does not necessarily mean they'll be able to get pregnant. So ovarian stimulation for embryo cryopreservation, embryo freezing, or oocyte cryopreservation, egg freezing, is the best method we have to preserve one's reproductive potential in women who are diagnosed with cancer, and remains the most likely strategy to result in a future pregnancy. And women with a BRCA mutation may consider a prophylactic salpingo-oophorectomy, which is excision of the fallopian tubes and ovaries in order to decrease future cancer risk, and that also applies to women who have Lynch syndrome. And guidelines, especially for BRCA women, recommend a risk-reducing bilateral salpingo-oophorectomy, or commonly referred to as a BSO, between the ages of 35 to 40, or individualized based on age of onset ovarian cancer in a family member and once childbearing is complete. And studies show that a BSO significantly reduces the risk of future ovarian cancer. A newer alternative risk-reducing strategy is a risk-reducing salpingectomy, so first taking out the fallopian tubes, followed by a delayed oophorectomy, so taking out the ovaries a few years later down the road. And this new strategy is based on growing evidence that the fallopian tube is actually the origin of the ovarian cancer. However, the data on the effects of ovarian cancer risk reduction with this new strategy are lacking, and this is currently not standard of care. And these interventions to reduce cancer risks often elicit fertility and family planning concerns among young BRCA mutation carriers, as also in terms of women with Lynch. And children of a BRCA mutation carrier have a 50% chance of inheriting the genetic mutation, and that also applies to women with Lynch syndrome or almost any hereditary cancer predisposition genetic mutation. And these women and couples have the option of doing IVF with PGD, which is pre-implantation genetic diagnosis, to prevent transmission of the gene to the offspring. So they have the option to end the cycle. There are conflicting studies that exist regarding the effect of a BRCA mutation on fertility. There are multiple studies that suggest that BRCA mutation carriers, more BRCA1 compared to BRCA2, may have decreased ovarian reserve, so lower egg quality and quantity, compared to a woman without a BRCA mutation. There are also some studies that have implied that BRCA mutation carriers who undergo IVF may not do as well as compared to non-BRCA carriers. However, there are some studies that have failed to demonstrate an association between BRCA status and fertility. As far as I'm aware, there's not any studies that looked at these effects in women with Lynch syndrome or any other genetic mutation associated with the cancer syndrome. It's mostly been looked at the BRCA community. So AMH, which stands for anti-Müllerian hormone, is a common blood test that we use to assess one's ovarian reserve. And usually at the first visit when we see a new patient, we'll draw an AMH level. And nowadays we actually get the results the following day. And it's an excellent marker of ovarian reserve. And there have been multiple studies that have looked at AMH levels in BRCA mutation carriers. And some of the recent studies have shown that BRCA mutation carriers may have a lower AMH concentration compared to non-carriers. Interestingly, a more recent study also looked at AMH in BRCA carriers, and they actually found that AMH concentrations were lower in BRCA2 patients. And that's one of the first studies that's shown an ovarian reserve effect in BRCA2 carriers, when most of the studies that have shown anything, it's been in BRCA1 carriers. Our team has also looked at this in terms of our patients, and we presented an abstract a few years ago at the annual ASRM conference, which is the annual infertility conference, and we too found a trend towards age-related decline in ovarian reserve and egg yield in BRCA1 carriers. So BRCA carriers, as well as anyone with Lynch, are faced with difficult issues regarding their desire to conceive. And there are various factors that may influence their decision. For example, if they plan to undergo a risk-reducing surgery, taking out the fallopian tubes and ovaries, and also when. And these women have the option of freezing eggs or embryos before the risk-reducing surgery to have for the future. What some women don't realize is that you don't need ovaries in order to carry a pregnancy. One could actually take hormones to support an early pregnancy before the pregnancy takes over. Another factor that may influence their decision include the potential risk of diminished ovarian reserve. As I mentioned, there have been some studies suggesting that BRCA women may have ovarian reserve issues. Risk of passing on the mutation to the offspring also may influence their decision, as 50% of the offspring will be a carrier. Other factors that may also play a role include how old they are, whether or not they're single or married, and how big of a family they ultimately desire. So when it comes to options for these women, if they're single or not in a committed relationship and are considering a risk-reducing BSO in the near future prior to either starting or completing a family, they have the option to freeze their eggs before the surgery and then therefore have the eggs to be used in the future. Or if they're young and say have diminished ovarian reserve, they too could freeze their eggs. In the future, these eggs could be thawed, fertilized, and can also undergo biopsy and PGD if they're interested to prevent passing on the gene to the offspring. For women who are married or in a committed relationship and are considering a risk-reducing BSO in the near future before either starting or completing a family, they too have the option of freezing embryos. Or if they're young and have evidence of diminished ovarian reserve, they too could freeze embryos. And once again, if they're interested, they could also do PGD, prevent transmitting the gene to the offspring. For women or couples who are not ready, say, to freeze eggs or embryos, but do want to be proactive, one option they have is we can monitor the ovarian reserve annually, given the possible increased risk of diminished ovarian reserve. And we could do this by doing the blood test, checking the AMH level, or doing a follicle scan of the ovary, looking at the follicle count. And if there's any evidence of decline, they could then choose to be more proactive. It's also important to remember that these women and couples may choose no fertility-related treatment or monitoring. So what does an IVF or egg freeze cycle involve? So these cycles involve taking these hormone stimulation medications, which are tiny shots given in the lower belly, and nurses teach our patients how to do these shots. They could take an online class, we could teach them in person, and they take these tiny shots daily, which cause multiple follicles in the ovary to grow, and we monitor the response every few days with bloods and ultrasounds. And these are early morning visits. We get our patients in and out of the office, usually well under 30 minutes. And they take the shots about 8 to 12 days until the ovaries are ready. And when the follicles are ready in the ovary, they take what's called the trigger shot. At 36 hours after taking the trigger shot, they undergo what's called the egg retrieval procedure. And this is done in the IVF lab. There's an anesthesiologist, and patients receive IV sedation. And while they're sleeping, using a vaginal ultrasound attached to a needle guide, vaginally puncture the ovaries into the follicles, and we aspirate the eggs, so we suck out the eggs. And the egg retrieval is a minimally invasive procedure and takes normally less than 15 minutes to complete. We'll then recover our patients for a little bit under an hour, and they'll go home feeling sore and crampy. And women who work generally go back to work next day feeling a little sore and a little bloated. We'll freeze the majority of the eggs on the day of the retrieval. If they're immature eggs, we'll culture them in a dish overnight and freeze them the following day. For women creating embryos, we then combine the sperm and eggs in a dish on the day of the retrieval. And here's a video of what the egg retrieval looks like. Okay, so here you see the needle piercing the ovary into the follicle and aspirating the fluid. And basically what we do is we go from follicle to follicle, draining the fluid until all the follicles are emptied. And then we hand off the fluid to the embryologist to see if an egg is present. So, women creating embryos, many times will do what's called ICSI, which stands for intracytoplasmic sperm injection, which is when you inject one sperm into the egg. And in any case where we're going to biopsy the embryo, we always do ICSI. And here's a video of what the procedure looks like. So here we see, motile sperm, and the embryologist using a needle to aspirate one of the motile sperm, and then they'll inject that single sperm into the egg. We'll then culture the embryo out to the blastocyst stage, which is a day 5 to day 7 embryo, and then they either could freeze the embryo, or if they're going to undergo the PGD and biopsy, we'll biopsy at that stage, which is a day 5 to day 7 embryo. So here we see, a mature egg, and the embryologist uses an instrument to stabilize the mature egg, and then the needle containing the sperm is carefully introduced into the egg, and you'll see in a second, this single sperm is released, and then they'll check the following day to see if fertilization occurred. And if you watch closely, you'll see that single sperm being released. So in the future, when someone's ready to use one of those embryos, they then take some hormone to get the lining ready. Once again, you don't need ovaries. Or for someone who froze eggs, they could fertilize the egg, culture them, and then undergo the PG and biopsy, and then they take their hormones to get the lining ready. So it usually takes about 2 weeks or so to get the lining ready before we put back the embryo. The embryo transfer procedure is also done in the IVF lab. It's done while they're awake. We have our patients have a full bladder, and using an abdominal ultrasound to help guide their procedure, we then place the speculum and then pass a tiny catheter through the cervix and release the embryo near the top of the uterus under ultrasound guidance. And this procedure usually does not involve any sedation, and it really only takes a few minutes, to complete. And here's a video of what it looks like. So above you can see the bladder. So here's the bladder, here's the uterine wall, and here's the lining. And if you watch closely, you'll see the catheter containing the embryo pass through the cervix and deposit the fluid containing the embryo near the top of the uterus. Let me get back to that. So you see the catheter being advanced, and then you just saw the fluid being released when that contains the embryo. And then the catheter is carefully withdrawn. So in the beginning, egg freezing, it didn't work that well. And the reason it didn't work that well is the process we used to use to freeze eggs, which is a process called slow freezing. The problem was when you would unfreeze the eggs, so when you thaw the eggs, a lot of them would not survive the thaw. Bless you. And this resulted in not great fertilization rates, embryo development rates, subsequent pregnancy rates. Over the course of time, we've changed the way we freeze eggs to the same way we freeze embryos, which is a process called vitrification. And with vitrification, that has basically revolutionized egg freezing. It's been a game changer. So now with vitrification, now when you unfreeze the eggs, it results in excellent survival rate, fertilization rate, embryo development rate, and subsequent pregnancy rates. And studies have shown the chance of conceiving using frozen eggs is almost the same as getting pregnant with fresh eggs. And the way to look at success is to compare someone who has age-matched fertility. So what does that mean? So someone who's freezing eggs, say at age 39, the chance of getting pregnant is similar to someone who's 39 who had infertility who's undergoing IVF. What I usually tell my patients is probably a little bit less than that, but where in the past embryos did much better than eggs, now the difference is very minimal. So embryos do slightly better than eggs, but not by much anymore. So because of this, in 2012, ASRM, which stands for American Society of Reproductive Medicine, which is the governing infertility agency in the United States, they revised their committee opinion on egg freezing and said it was no longer experimental because we had excellent evidence demonstrating success rates similar to fresh IVF, and also that it was safe, with no increase in chromosome abnormalities, birth defects, or developmental deficits in the offspring. So a frequent question we get is, how many eggs does one need? But the best way of answering this question is based on the age of the woman. And it's also important to remember that one egg does not necessarily equal one baby. So the ideal number varies based on the age of the woman and how big of a family they ultimately want. And usually a good rule of thumb is about 10 to 20 mature eggs is a common goal. But the older you are, the more eggs you typically require. And a study published a few years ago looked at the number of mature eggs needed to achieve a single live birth. And what they found was, for women under 35, they need about 8 mature eggs, 35 to 37, about 10 mature eggs, and 38 to 40, about 14 mature eggs. Once again, this is an average. And this does not necessarily, correlate with someone who's going to, who plans to do IVF and do PGD, prevent transmitting the genetic mutation. Because in those instances, you almost need double the amount. This applies to kind of all comers, but if you're doing PGD, you almost need double the amount because you're going to eliminate some embryos that would be chromosomally normal, but may be affected. And we'll talk more about that in a little bit. So PGD, or pre-implantation genetic diagnosis, is a diagnosis of a genetic condition prior to achieving a pregnancy. And PGD is the only way to determine whether an embryo is predicted to be affected with a genetic condition prior to achieving a pregnancy. And in women and couples undergoing a PGD cycle, they need to create what's called a DNA probe, which is a specialized linkage marker to that specific gene for the embryo. And in order to do this, they either they need a sample of blood or a swab of cells from the cheek, from the patient, the partner, and sometimes they also ask for some family members to make it more specific. And it takes about 1-2 months to create this specific probe. And an IVF cycle involving PGD includes the process of fertilizing the egg, culture the embryo to the blastocyst stage, biopsy of the embryo, freezing the embryo via vitrification, and then DNA analysis to determine if the embryo carries a specific genetic disease such as BRCA mutation, Lynch Syndrome, or any identifiable genetic condition. So aneuploidy screening allows for the assessment of chromosomal abnormalities in the embryo, things like Down syndrome. And aneuploidy, which is a chromosomally abnormal embryo, is a leading cause of implantation failure and miscarriages in an IVF cycle using unscreened embryos, so embryos that you don't biopsy. And aneuploidy increases with increasing maternal age, and is why older women have lower pregnancy rates and higher miscarriage rates in general. And in all PGD cycles, embryos also undergo this aneuploidy screening. And this process allows us to identify the single healthiest embryo that's unaffected with the genetic mutation, so unaffected with a BRCA mutation, Lynch, or any mutation, and that's chromosomally normal, or euploid. And these embryos can be later thawed and transferred in a future frozen embryo transfer cycle, often referred to as an FET. And these excess euploid and unaffected embryos can be saved for future attempts of pregnancy, since these embryos can remain frozen indefinitely. They do not age. So here's what a biopsy of an embryo looks like. So this is a blastocyst stage biopsy. So day 5, day 7 embryo. And the embryologist uses a suction pipette to aspirate some of what we call the trophectoderm cells. Those are cells that are outside of the placenta, that are on the outside of the embryo and are destined to become the placenta. So remove all those cells that's not harmful to the embryo. And using a pulse laser beam, they're able to transect a few of those cells. We then freeze the embryo, and these cells get sent to the specialized genetics laboratory to be analyzed. And depending on the lab it goes to, it takes about 1-2 weeks to get the results of the biopsy. So there was an interesting study published about 8 years ago based on a focus group that took place at the 2009 National Force Conference. And the purpose of the study was to assess the informational needs of a BRCA mutation carrier regarding issues of fertility and pre-implantation genetic diagnosis options. And the results of the study highlighted the important psychosocial concerns and informational needs within this patient population. And they explored the informational needs of women who are BRCA carriers regarding issues of reproduction and views on PGD. And participants at the time believed that information about fertility and PGD was not well discussed by healthcare providers. Some of the other findings from this group included feelings of guilt about transmitting the mutation to future children. They also felt that there was a limited quantity of information about fertility options at the time. Most felt a sense of responsibility to take advantage of PGD, but thought a lack of information about the process and procedures existed. And the majority agreed that even if IVF with PGD was not pursued, there was still an implied responsibility to at least consider options. So interestingly, not a lot has changed, in my opinion, over the past decade or so. And I make this statement based on some abstracts that have been presented at the annual ASM conference over the last few years. For example, one concluded that a targeted referral for fertility preservation consultation at time of BRCA screening may help women improve knowledge and allow improved decision-making about one's reproductive options. A more recent study concluded that BRCA carriers desire and would benefit from reproductive counseling after being informed of their carrier status. So despite understanding of the medical implications of a BRCA mutation, Lynch, or any heritable genetic mutation associated with cancer, there is still limited data on how knowledge of the carrier status influences decisions about reproduction and parenthood. And BRCA carriers, or anyone with Lynch, may benefit from reproductive counseling after being informed of the carrier status and therefore improve knowledge and allow improved decision-making about one's reproductive options. So I know we've been talking about fertility treatment for these women, but an important question to ask, is it safe? In general, when it comes to fertility treatment in women at risk for developing ovarian cancer, say due to BRCA or even Lynch, there's not a lot out there. But of the studies that are out there, the studies suggest that fertility treatment does not increase the risk of ovarian cancer among young BRCA mutation carriers. Similarly, the studies have also reported no harmful effects of these medications on BRCA-associated breast cancer. So even though there's not a lot of studies, the studies show that it's safe. A more recent study looked at ovarian stimulation with the concurrent use of a medication called aromatase inhibitor called Letrozole. And what this does is it keeps the estrogen levels low during the cycle. And they found that it provides not only a safe fertility preservation option for women who are diagnosed with cancer and undergoing fertility preservation treatment, but also BRCA mutation carriers. So when it comes to options for a woman, say, with BRCA or Lynch, a lot of it depends on whether or not they plan to do PGD to prevent transmitting the gene to the offspring. So for women who are planning to do PGD, either at present time or sometime in the future, that kind of affects how they may proceed. So for these women or couples who plan to do PGD, if they have diminished ovarian reserve and are single, they have the option of freezing eggs. Or if they have diminished ovarian reserve and are married, they could do IVF, PGD, and bank embryos, so trying to create enough embryos to build the future family they ultimately want. For women with normal ovarian reserve and who are single, they have the option of freezing eggs. Or if they're young, say under the age of 35, and are not ready, say, to freeze eggs, one thing that we can do is we can monitor the ovarian reserve, and if there's any evidence of decline, they could freeze eggs at the time. And once again, those eggs could be used to create embryos to then undergo future PGD. For married couples with normal ovarian reserve, once again, they could do IVF, PGD, and bank embryos. So once again, trying to create enough embryos to build the future family they want. Or if they're young, say under the age of 35, and they're not ready to do IVF, we can monitor ovarian reserve. If there's any evidence of decline, they could choose to do IVF, PGD, and once again, trying to create enough embryos to build the future family they want. For women and couples who are not interested in PGD, their options I think are slightly different. So if they have diminished ovarian reserve and are single, they could freeze eggs. Or if they're young, say under the age of 35, and they're not ready, to freeze eggs, we could monitor ovarian reserve. If there's any decline, further decline, they could choose to freeze eggs at the time. For married couples, once again, they could still choose to do IVF without PGD and bank embryos, especially if they're considering a risk-reducing surgery before either starting or completing a family. Or say if they're young and say under the age of 35 and they're not ready to try and get pregnant on their own or do IVF without PGD, we can monitor ovarian reserve. If there's any further decline, they could choose to try and get pregnant on their own or still do IVF and bank embryos, once again without PGD. For women with normal ovarian reserve, options are similar. If they're single, they could freeze eggs, or if they're young, say under 35, we can monitor ovarian reserve. If there's any decline, once again, they could choose to freeze the eggs at the time. Or if they're married, once again, they could still choose to do IVF without PGD and bank embryos, once again, especially if they're considering the risk-reducing surgery before starting and completing the family. Or once again, if they're young, say under the age of 35, we can monitor ovarian reserve. If there's any decline, they could choose to get pregnant on their own, or still do IVF without PG and bank embryos. I think there's less of a role of monitoring ovarian reserve in women who are older than the age of 35 for two reasons. Number one, the success of these fertility treatments starts to go down with age. Number two, many of these women may choose a risk-reducing surgery, so I think there's less of a role of monitoring ovarian reserve in women who are a little bit older. The other thing that I really want everyone to take home is I can't emphasize enough the effect of age on the success of these fertility treatments. Okay? Age plays such a major role. So in women who know they want to do PGD at some point in their life, who know they want to do PGD, prevent transmitting the gene to the offspring, I really encourage them to freeze eggs or embryos when they're young. And the reason I make that statement is the younger they are, the more likely to get a lot more eggs, and the more likely to get a lot more eggs that result in a chromosomally normal embryo. Because remember, 50% of those chromosomally normal embryos are going to be affected. You're going to be not wanting to use because that was the goal of doing that in the first place. So to me, it makes the most sense if that's what you want to do, take advantage of doing it at a younger age. You're going to get a lot more eggs, and those eggs are going to result in embryos that are more likely to be chromosomally normal. So I thought it'd be interesting to walk through some real live clinical situations. So here we have a 30-year-old BRCA carrier who's single, and in the future she would like to prevent passing on the mutation to her offspring. What can she do now? So she can freeze her eggs now, and in the future she can thaw her eggs, fertilize them, and then undergo PGD. Here we have a 33-year-old BRCA carrier who's married. She would like to have 2 kids in the future, but they're not ready to start the family now and want to wait 2 more years. They would also like to prevent passing on the mutation. What can they do? The couple can freeze the embryos after undergoing PGD, and when the couple is ready to start a family, they can then undergo a frozen embryo transfer of a single embryo that's unaffected and chromosomally normal. Here we have a 39-year-old recently diagnosed BRCA carrier who's single and plans on undergoing a risk-reducing BSO in the near future. She would also like to have kids. What are her options? So she can freeze her eggs prior to the risk-reducing BSO. Here we have a 37-year-old recently diagnosed BRCA carrier who just got married. She would like to undergo a risk-reducing BSO soon, but ideally wants to have 2 kids. What can she do? So the couple can freeze the embryos prior to the risk-reducing BSO and also have the option of doing PGD if they're interested. And when the couple is ready to start a family, they can then undergo a frozen embryo transfer cycle. So for anyone who's interested in reading a little bit more about what we just spoke about, my team and I, we recently published an article entitled Caring for BRCA Carriers, Strategies to Promote Health and Preserve Fertility. So if you're interested, you can find this article online. So just to summarize, despite understanding of the medical implications of a BRCA mutation or a Lynch mutation, there's still limited data on how knowledge of carrier status influence decisions about reproduction and parenthood. And women at risk for development of cancer need a healthcare professional to discuss not only the medical implications of the carrier status or risk-reducing options, but also information regarding fertility, preservation, and PGD. BRCA carriers, Lynch Syndrome patients, and anyone with a heritable genetic mutation associated with cancer, They may benefit from reproductive counseling after being informed of the carrier status, and therefore improve their knowledge and allow improved decision-making about one's reproductive options. And it's also important to remember that there's no one-size-fits-all treatment option that exists for these women and couples.